Welcome to the Deep Dive. Today we're tackling something that's really top of mind for those of us in medical education. How we actually evaluate continuing professional development, CPD.
Right. We all want to know if these programs are, really hitting the mark.
For years, the standard way, pretty much, has been looking at outcomes. Did knowledge go up? Were skills improved? Did patient care change? But, well, lately, there's a growing sense among medical education experts, ourselves included, that maybe this isn't the whole picture.
That's exactly right. There's this fascinating discussion going on, and it's really brought into focus by a really thought-provoking paper from Catherine Parker and Abu Manusud on principles-focused evaluation.
Ah, PFE.
Yes, PFE. Because as our CPD programs get more complex and healthcare systems themselves keep evolving and the decisions doctors face are, frankly, getting tougher, it's becoming clearer that just looking at those end results, those outcomes, it's a bit like, trying to judge a whole meal by just tasting the salt.
Okay, let's unpack that.
Yeah.
So the outcome-based model, it's been king for a long time,
Yeah.
right? Since Kirkpatrick's framework back in, 1954?
That's the one. 4 levels. Reaction, learning, behavior, results. The core question was always, did it work?
Did they learn the stuff? Did they change how they practice? Simple enough on the surface.
Yeah.
But the feeling now is that this might be a bit, well, maybe too narrow. Like you said, missing the bigger context.
Absolutely. Those outcomes are important. Don't get me wrong. We need that data. But they often fail to capture the messiness, the real-world complexities of how these programs actually operate within our health system.
So many variables.
Exactly. Just focusing on the endpoint limits what we can really learn. We need evaluation models that give us, truly meaningful information for making decisions, models that can handle different viewpoints from us as educators, and crucially, that help programs adapt and iterate almost in real time.
Which brings us neatly to principles-focused evaluation, PFE. Now, just to be clear, we're not saying throw out outcome measures entirely.
No, not at all.
It feels more like adding a really vital complementary lens, like switching from looking just at the what to understanding the how and the why.
Precisely. PFE actually grows out of utilization-focused evaluation. The core idea there is asking, is this evaluation actually going to be used? Will it help improve things?
Makes sense.
Principles-focused evaluation takes that a step further. Its main goal isn't just accountability, like ticking boxes or judging success against fixed metrics. It's about really getting under the hood of the program, understanding its values. So utilization-focused asks, will it be used? PFE adds, are we sticking to our core values, and does that make a difference?
And the basic idea here is that these CPD programs, they aren't just stacks of content. They're built and delivered by us, by medical education professionals. And our values, our experiences, our expertise, all that inevitably shapes the program.
Totally.
Right.
And PFE shines a spotlight on these actionable values. Michael Quinn Patton calls them principles. These are the fundamental beliefs intended to guide every decision made about the program.
So the evaluation looks at these principles. Are they clear? Do they mean something to us? Can we actually use them?
Yes, and are we following them? And importantly, what happens when we do, or maybe when we don't? What's the impact on the results?
So these principles, they're not just like fuzzy mission statements we hang on the wall. They need to be practical guides. The paper says they should be guiding, useful, inspirational, developmental, and evaluable. That's quite a list, setting a high bar for ourselves.
It is a high bar, and defining them is key. It can't be top-down. PFE really stresses a collaborative process, bringing the key stakeholders, us, together to actually co-create these principles.
That way, everyone feels ownership, and they reflect what we, as the medical education community running the program, genuinely think matters most.
Exactly. Buy-in is crucial.
Okay, so we've got these actionable values, principles, but how do you, nail them down so they're actually useful day to day? The paper mentions 3 elements. Can you walk us through those, like building blocks?
Yeah, good way to put it. First is the overarching definition. That's the big idea, the core value stated broadly. It gives general direction in tricky situations. Think of it as the main point.
Got it.
Then, operationalizing statements. These get more specific. They guide how you actually apply the principle in practice, like the specific actions that embody that value.
Okay, making it real.
Right. And finally, minimum specifications. These are the absolute must-haves, the bottom line. The rules or conditions you reasonably expect need to be met to get the outcomes you want while staying true to the principle.
Okay. That makes sense. Like core belief, how to act on it, and the non-negotiables. The paper uses a great real-world example, right? The SOPA-VH program. Tell us about that. Why is it a good illustration for us?
Yeah, Safer Opioid Prescribing, Effective Prescribing of Opioids for Chronic Pain program, SOPOSH. It started back in 2012, really in direct response to the opioid
A
crisis.
critical need.
Absolutely. It's an accredited CPD program designed to boost healthcare professionals' knowledge and skills in chronic pain management and safe opioid prescribing. And like many programs, it evolved over time, adding online components, trying to reach more people.
And I assume, like is pretty common in our field, they were using mostly traditional outcome evaluations. Maybe something like Moore's framework, looking at participation, satisfaction, learning, performance, patient outcomes.
Exactly. They had good data on those things. But as the program grew and the team wanted to expand its reach, new partnerships, different ways of delivering it, which many successful programs aim for, the leaders felt they needed something more.
Something complementary.
Precisely. They wanted to make sure that the core values, the things that made the program work in the first place, didn't get lost as it scaled up. That's where PFE came in. Not to replace the outcome data, but to sit alongside it, ensuring the program stayed true to itself as it grew.
So how do they actually figure out these principles for SOPO-CANH? As medical education experts, what was their process? Sounds like something we could learn from.
It was very intentional. They gathered the core team leaders, faculty, the people really driving the CPD. They started with a clear explanation of what PFE is all about.
Setting the stage.
Right. Then they did this really neat reflective exercise. They asked everyone to imagine the program, say 3 to 5 years down the road, being incredibly successful.
Okay.
And they asked questions like, picture SOPO-H knocking it out of the park. What does that look like? Where is it happening? Why are you proud of it? What core values are making that success possible? What's its impact?
Oh, that's clever. You picture the ideal future and then work backward to identify the values that underpin that success. Like asking, what made this imagined home run possible?
Exactly. They recorded and transcribed the whole discussion. Then the evaluator went through it, really focusing on the answers about what they valued most in that successful future state. Since principles are these actionable values.
That helped identify potential candidates.
Precisely. They drafted an initial set of principles and definitions. Then, crucially, they took those drafts back to the core team. It was iterative discussion, refinement, getting consensus, a real dialogue among the educators to define their shared compass.
And then, to make them practical, especially for wider reach, they defined those operationalizing statements and minimum specs you mentioned earlier. Makes sense translate values into actions and standards.
You got it. They asked the team, okay, for each principle, what are the absolute minimum things any delivery site or partner must do to uphold it? Building on the core principles, they hammered out the specifics. Drafts were made, leaders reviewed, then the whole team agreed. Everyone needed to be clear on how these principles would work in different places.
And the paper lays out the 6 principles they landed on. It's really useful for us in medical education to see that structure. Let's look at a couple. One was commitment to excellence, integrating knowledge, best practices. How do they make that concrete?
Sure. So under a commitment to excellence, one operationalizing statement was very direct. Program must reflect best practice, evidence-based guidelines in opioid prescribing. Clear enough.
Right.
And a minimum specification was, the program must be delivered by faculty who reflect the participants for whom the program is delivered. Which is interesting, it links content quality with relatable delivery.
That's a great point, ensuring educators connect with learners. Okay, what about another one? Accessible, making sure people could actually get to the program. Geography, culture, cost.
For accessible, an operationalizing statement was to actively identify individuals and groups that have the greatest need. Proactive outreach, and a minimum specification. The program must clearly identify the target population and also identify and adapt to specific needs of the target population. So it's not just identifying, but actually adapting.
It's really powerful seeing it laid out like that principle, definition, how-to statements, and the absolute must-dos. It takes it way beyond just aspirational words.
And they didn't stop there. As you'd expect from thoughtful medical education pros, the SOPA-CH team created tools to weave these principles into their actual work.
Oh, like what?
They developed a minimum specification checklist. They use it during program planning now to make sure they're hitting those agreed standards. And they even designed a participant survey to get feedback specifically on how well the program is living up to its principles from the learner's view.
So it shifts the evaluation focus. It's not just, did your knowledge improve?
Yeah.
But also, are we, the educators, actually walking the talk? Are we embodying our core values in how we do this?
Exactly that. The paper makes this really strong point, and it resonates, I think, for all of us in this field. Traditional evaluation asks, did it work? Focusing on the facts, the outcomes. PFE deliberately brings values into the equation.
It acknowledges that our beliefs, our values as educators, they really do shape how we design and deliver programs, especially for complex stuff like the opioid crisis.
Right. And PFE isn't about judging those values as right or wrong. It's about asking, are these principles clear? Are we sticking to them? And what difference does that actually make? It's evaluation focused on learning, on improvement, recognizing how central our values are to success in medical education.
And this PFE approach seems to have some real strengths for us. Like,
Right.
it measures program value beyond just satisfaction scores or test results, right?
Definitely. The principles can capture the deeper essence, the value-driven purpose of the program.
It also feels like principles might be more transferable, more adaptable across different contexts than, say, a really specific activity.
That's a key point. If you understand your core principles, excellence, accessibility, integrity, you can figure out how to apply them effectively in different settings with different learners. Patton's quote in the paper is great. Principles as a rudder for navigating complex systems.
I like that. A rudder gives direction but allows you to adjust for the currents, perfect for the changing seas of medical education.
Exactly. Specific activities might need tweaking for different audiences, but the core principles, that commitment to quality, to reaching learners, to ethical practice, those can be the constant guideposts. That adaptability makes programs potentially much more scalable and sustainable in their impact.
Now, to be balanced, the paper does note limitations. PFE might not be the best fit if your absolute top priority is rigid standardization, making sure everything is identical everywhere.
True.
And if the evaluation is purely about accountability to very specific predetermined steps or outcomes, maybe a traditional model is better suited for that particular job.
Those are fair points to keep in mind. PFE really comes into its own when you're dealing with complexity, when adaptability matters a lot, and when you want that deeper understanding of why a program works, what its core drivers are. It's not a magic bullet for every evaluation need we have, but it's a really valuable addition to our toolkit.
Okay, so wrapping up this deep dive, it really sounds like principles-focused evaluation gives us, in medical education, a really insightful way to look at our CPD. It's not just, did it work based on outcomes,
Okay.
but also looking critically at the values, the principles that shape the whole thing. Design, delivery, everything.
Exactly. It's a way to help ensure our programs stay true to their purpose, maintain their integrity, even as they grow and adapt for different learners and settings. And by focusing on learning through that lens of guiding principles, we get a much richer, more layered understanding of the program's impact.
It really makes you think, doesn't it? For any initiative we undertake as medical education professionals, what if we explicitly identified and evaluated our core principles? Could that help us create more adaptable, more meaningful, ultimately more impactful programs, especially as we tackle these big, complex challenges in healthcare? Definitely something valuable for all of us to consider. Thanks for digging into this with me.
My pleasure. It's a fascinating and important shift in how we think about evaluation.